Hello, and welcome to the TIFF podcast, where we explore the world of public health, interviewing registrars, academics, and leaders in the profession. My name is Kazim Bibijan, and I'm a specialty registrar in public health in the UK. The aim of this podcast is to offer a wide panoramic of what it means to work in public health, while hopefully providing some inspiration to those who would like to train in the profession. It is my absolute pleasure to welcome Dr. Ebere Okereke to the podcast. Ebere is a public health doctor specialising in global health security and health system strengthening. Ebere has built her expertise over a number of senior roles, including as a senior health advisor at the Tony Blair Institute for Global Change, as a CEO to the Africa Public Health Foundation, co-lead for the Africa CDC Partnership for African Vaccine Manufacturing, and a senior public health advisor for the Africa CDC, and was also the former lead for the Public Health England's IHR Strengthening Project. Ebere is an associate fellow of the Global Health Programme at Chatham House, and she's received numerous awards for her work promoting women and underrepresented groups in public health leadership. Ebere, thank you so much for joining the podcast.
Thanks for having me. I'm very flattered to be invited.
So I guess perhaps let's start with a little bit about your career story, which I think, from listening to interviews is a really fascinating kind of evolution from Nigeria to the UK to global and vice versa. Could you kind of describe to our listeners how you discovered public health as a field and why you went down that career route?
Well, that's an interesting one. I think we all start up. I didn't have very much significant exposure to what was at the time called community medicine when I was in medical school. First of all, I went to medical school in Nigeria, the University of Nigeria, and we had a very short postings, as they used to be called then in the sort of last 2 years of medical school, called community medicine. And what we actually did was much more occupational health. We did, visits to the coal mines, a few outreaches for reproductive health education type movements, but not really much. There wasn't actually a specialty that was on my radar at all for a very long time. And so I went into clinical practice initially, as was the time. At the time when I graduated medical school, most women were expected to go into general practice or pediatrics. I found pediatrics too emotionally draining. I couldn't deal with sick children. And so I went to general medicine and really interested into elderly care medicine because I really liked talking to old people and hearing their stories. One of my particular interests is history, and oral history from lived experience of the elderly patients was really interesting. But I started getting curious about why we were seeing the same people coming back over and over to our acute medical care. And that was just a little background niggle. And then I had one of those eureka moments, not in the sense of knowing what, but knowing what I didn't want to do, where my consultant at the time paid me a very good compliment about saying that, I was working really well and he could see me sitting in his chair sometime in the future. And I basically had a panic because I became very clear that wasn't where I wanted to be. So I did something that perhaps isn't very wise. I resigned from the general medicine residency I was on, and with no particular plans, and just said, I'll study freelance for a little bit, local for a while and decide what I want to do. I went to Liverpool School of Tropical Medicine, did the diploma in tropical medicine, mainly because in our pre-med year in Nigeria, I did parasitology and had the first female professor that I actually had contact with was Professor Amazigo. She went on to lead the WHO Onchocerciasis eradication program in West Africa. She's an amazing woman. And so I thought, I'm going to do something related to that. So I did the 4-month diploma in tropical medicine at Liverpool. And during that program, we had a series on community. It was still called community medicine at the time. And Professor Adetokunbo Lucas from WHO at the time gave us a talk about what we now call health protection, but was very clearly communicable disease control. He wrote a book about it. And I had one of those light bulb moments. I said, yes, this is what I want to do. It married my interest in prevention with my interest in infectious diseases and communicable disease control and infectious diseases. So I went back to clinical infectious diseases and then started applying to get on the public health program. I remember at the time the regional advisor for the faculty was Dee Kyle. She's long retired now. And her enthusiasm for the specialty was just what I needed. And so I went in to apply for the training program and started my public health training in Sunderland and then subsequently moved to West Yorkshire. So I went into public health focusing on communicable disease control. And it brought communicable disease control and emergency preparedness and response tend to go hand in hand because you go from outbreaks to, prevention and preparedness and all that. And that gradually morphed from, CDC and being a CDC to doing more on health protection, emerging infections, zoonosis, and seemed to just naturally flow into global health. So that's 30 odd years in a nutshell.
That's really fascinating that from that one moment that your senior says, I can imagine you in this position and that setting off, a whole series of thoughts of, is this where I want to be?
He was very disappointed. He was upset. He took it really personally. And it was, I actually went back late and said, you did me an amazing favor because I was not on the right track. And it took someone actually pointing out that I was where I was heading for me to realize that wasn't where I needed to go. And sometimes we all need in our career and life journey someone to actually cause you to pause and check whether you're heading where you want to be. Yeah, so
exactly. I love that story, and I guess you kind of condensed it all down. But you were on that kind of you were a CCDC for a period. Obviously, you trained in the north. Was it the northwest as a registrar?
It was maybe Northern and Yorkshire region.
Northern and Yorkshire region.
Yeah, it was Northern and Yorkshire region at the time. Yeah.
Yeah, and that transition, I guess, from UK-based kind of CCDC role, I guess how would you summarize that story from going from CCDC to those early steps towards global health and being involved in that kind of global policy arena? Was that something you'd always thought about while you were CCDC, that you always wanted to potentially contribute back to the African public health system?
Not explicitly. I trained in Nigeria. I'm Nigerian. I'm dual national and all that, but my entire cultural orientation is Nigerian. When I left Nigeria to study first in Trinidad and Tobago before I came to the UK, the plan, as most people will tell you, is 5 years, I'll go back. 5 years became 10, 15, life intervenes, you adjust, you accommodate, and that sort of going back becomes more and more remote. Also, it becomes much more difficult because you're now completely trained in a different health system, and it just looks almost impossible to do what you originally planned, which is come back and work in the system that you grew up in, and that I also think we, having gone to medical school here, free. Relatively compared to, we didn't pay tuition fees, so I was effectively educated by Nigeria, so it felt absolutely right that I should return and give back at some point. But you just kind of get into a routine, and it becomes something that's at the back of your mind, but you're not intentional about. But one of my passions has always been, and with hindsight, my first contact with the public health system was tuberculosis. When I was about 10 years old, we had a cousin come to spend the long vacation, as we called it in Nigeria, the summer holidays, with us in town where we lived. And she was within a very short while of staying with us. Dad, who's a physician, identified that she had TB, and she was diagnosed, confirmed, and we all got screened. We all had chest x-rays. I didn't know what that was at the time, but with hindsight, I realized this is unusual, this disease where the intervention isn't just about, taking, I was used to, you got sick, you got tablets, you got better. But everybody around her had to get screened. She was on treatment for a very long time. She was isolated. And when I then came into public health, I started thinking again, we have all these new, even for TB, that is still underinvested in, I believe, and resourced in terms of the fact that we're still reliant on very old therapeutics and diagnostics. But I said, we're doing, I was regional lead for TB for a while, and there's not that much TB in the UK. There's enough, more than there ought to be for a country with its economic state position and resources. But I kept thinking, I'm here, what I felt was, twiddling around the edges of a manageable program. And it's still a huge thing. The burden of tuberculosis, morbidity and mortality in Nigeria and in most of Africa is still quite high, quite significantly so, worsened with the, HIV co-pandemic. And for a long time, it didn't get that surge of investment in HIV, AIDS didn't actually include tuberculosis. So I started looking for opportunities to be able to reconnect with the public health system here. And I know my initial explorations were around, I happened to know someone who knew the then Minister of Health in Nigeria. And I came back and I said, this is what I do. This is my experience. How can I contribute? And it was really difficult to fit into the system. Plus, I also at the time had a family who were, my daughter was in school, moving was not an option. So it kind of, again, fizzled out. But I was always started to get involved in the conversations in the global health space and to sort of address the frustration of the fact that if you had multi-drug resistant TB in sub-Saharan Africa, it was a death sentence, even though there were interventions that were possible. I remember getting into conversations with the manufacturers of what was then the quantiferon test for latent TB at the time, about access to those diagnostic tools in the countries where there's so much more burden and the barrier of cost. And so my thinking about, global health from the get-go was always focused looked through the equity lens. But what challenged me to actually, and again, I do have a habit of I'm in a position and it makes sense, I know where I'm going and I'm comfortable with the status quo. I tend to get those sort of somebody challenges me or something challenges me to step back and look at where I'm going again. And this one was actually there used to be a TEDx series called TEDx Houston, which Chikwe Hapazon was one of the founders and organizers of that. It was focusing on Africans in Africans in the diaspora. And there was, I think it was either the first or the second one of these series I went to. We were all challenged. How are you going to give back to the countries and the regions that we come from? And I said, I challenged myself, and I publicly stated it, wrote it there, that I will now start intentionally working towards going to work in to support the African region. And so again, I went back to Liverpool School of Tropical Medicine. It features a lot. I love Liverpool. I like the School of Tropical Medicine. And so I went back there and did an international health consultancy course because I said there must be other ways to get involved. But what that taught me actually was that I shouldn't, because I was initially looking at going back to lecture in universities or stuff like that. I said, no, what I actually needed to get involved with was health systems. That's the conversation that needs to be had and how we change them and improve them. And serendipitously, just around the same time, Health Protection Agency at the time advertised an internal secondment opportunity to work with IRC in Kenya. And so I applied for that, got it, and spent a year working with the International Refugee Committee, doing some work with the refugee camps in Kakuma and Dadaab. And the aim then was to try to develop a community health strategy to move them away, because most of the service delivery had been reactive. It was emergency response mode, but these camps had now been there for 20 years. People were developing chronic diseases, lifestyle-related conditions, and they wanted to restructure the system to address that. And that was that was it. That was well, this was fulfilling. This is where I need to be. And so on the back of that, I came back to work in then PHE's global health team, and then the ICHA project, and moved on from there. And that's how I ended up in global health.
Again, I love that moment of reflecting on where am I now and where do I want to go on that the TEDx
Mm,
point that you made. That's really fascinating.
mm,
So I guess coming back to the public health question that we partnered with the faculty
mm,
on, and obviously you have such a, I guess, broad public health career experience from, training in medicine to infectious diseases to global health. Um, and public health is such a broad specialty and career, and I guess it's no sort of single thing. I guess
mm.
in your own words, how would you define what public health is?
There's so many great definitions out there from the WHO one, which, if you consider when that was articulated, is an amazingly forward-thinking definition. But I tend to focus it on slightly narrower, in a sense, in terms of the foundations, and so it is really about organized effort. So it's not about ad hoc issue. It's not ad hoc interventions. It's organized. It's got to be about. So the key factors that define public health means organized effort. Whether it's in the public or in the private sector is irrelevant. It's about organized effort. For me, the focus is about policy, education, intervention, because it's not about. It's about what we do, and what we do in health generally is driven by policy. And it comes back to something I'm very passionate about, which is the role of politics in public health. And the goal has got to be to achieve equitable access to resources that allow individuals and communities and societies to collectively or individually make the healthiest choices possible. So you might never see a patient with a disease, because the disease is irrelevant. The disease is the end product you're trying to prevent and avoid. Sometimes it's not avoidable, but in every circumstance, what we're looking at is how do we ensure that the policy, the system, education is really important, in the sense that that's probably outside, immunization and clean water, the most impactful long-term thing in terms of improving health experience and health outcomes, and having those conversations fairly upstream with the whole goal of equitable access to whatever resources are available, but putting individual choice back into center of it, because we can't make people do things. You can enable the right choices to be the easiest choices. And so I always get irritated when people refer to public health as the nanny state. That isn't fair and isn't true. What public health is about is most people want to be well, they want to live long as possible, they want to be healthy, they want to be happy. And what we should be about is providing the tools through education for the individuals, provide them policy to provide the system and the investment and the interventions that will allow people to then, as community, because we're not talking about just individuals, it's the collective behaviors that really improve health of society. So if you're the only healthy person in a sick community, you're not going to be particularly healthy or happy. So that's how I see public health, and that equitable access is so important, because I don't believe that we can achieve the truest experience of health, which includes, it's happiness, well-being, the full broad sense. The more inequitable a society, the more stark the adverse health experience are, even in those with access to resources. So that's how I define it.
No, I really like that, the
Mm,
different factors in that definition about equity and collective effort. And it's probably a good segue to talking about some of the kind of global health issues that you've been involved in. I guess for listeners that, potentially not aware of global health in depth as a field, but
mm,
it's, as you said, about politics. It's a really unique mix of issues in play with global health, whether it's
mm,
health, science, medicine, history, power, conflict, human rights. How
mm.
would you describe the field of global health? Because it's quite a complex area at times.
Well, that's that's a whole lecture on its own.
Oh yeah, for
But
sure. It's a call.
yeah, but let's look at the historical. Again, I'll keep going back to history because when I finally properly retire from global health, I'm going back to study history. It's an interest I've always had. But if we look at the history of what is now called global health, we need to, that's why I keep saying you can't talk global health, you can't talk public health, and you definitely can't talk global health without looking at the political levers and the political climate that led to that sort of influenced the whole evolution. So we would have to go back to colonial medicine. So where colonial medicine, tropical medicine was very much about the colonialists studying the diseases so that they would, not because they were interested in the populations that were affected in the countries they invaded, to protect themselves. So there was and therefore it was actually very military driven, because most colonial adventures started and were supported by military, by the armies of the countries that were colonizing. So it was trade and military. And then the church was the soft power that allowed them to actually make the cultural adaptations that embedded colonialism, and for which we're still struggling with today. So we start from that sort of, colonial medicine, military medicine, tropical medicine, where the interest was we need to understand these diseases of those people so that we can protect ourselves where we're in their territory. And then the sort of move away from formal recognized colonialism. Colonialism started to shift, and there was a recognition that there was, and I'm being very sarcastic here, people started to think, oh yeah, this isn't, when we shouldn't be this nasty to people. Theoretically, they changed the language a little bit, and it became international health. And international health was always the things that happen out there, not here. And it was a global north, global south. And I use those terms advisedly because they're not necessarily geographically accurate, but we know what they mean. It was that sort of, global north intervening to improve the health experiences of people in the global south on the topics and the issues that they deemed were relevant, important, and or of interest. And then we've moved from international health to now starting to call it global health. For me, what is interesting and what is unique about the language of global health is that it comes back to my favorite word, which is around equity. It's a recognition of the need to look at health and its experience and the opportunity to achieve optimal health experiences through the equity lens. And that means, and I remember being approached in London once after a talk by someone who said, I want to do global health. And she happened to live in my favorite city, Liverpool. And so I said to her, so what are you doing to address health inequity in Liverpool? And she said, no, I don't want to work in Liverpool. I want to go and do this in Africa. Yeah, we'll unpack that, Africa term. And so I had a conversation about, look, it's about inequity, wherever it occurs. And the fact that in some parts of Liverpool, the health outcomes and the health life expectations are so much more different than from some, across the river in the Wirral, for example. That's a global health issue, because it's those inequities that perpetuate the long-term complications that we are then worried about. And so for me, global health is actually about how do we ensure that wherever you are geographically, whatever your nationality, ethnicity, culture, religion, language, you're equipped, there's opportunity for you to maximize your health outcomes. And that's about ensuring that whatever resources are available can reach people wherever there is a need. And that is political, because we need policies that enable those, that prevent the sorts of, and those policies are not necessarily health policies. Let's look at trade policy, for example. Trade policy is one of the biggest barriers to the flow of health products from one region to the other. Trade policies are the reason why in the middle of a pandemic, you couldn't export reagents to other countries because countries decided to hoard them for themselves. So again, it comes back to what I'm saying is about looking at policy in its broader sense, not just a health policy. and looking at what do we put in place in our societies as a globe, particularly focusing on those things that cross national barriers. How do we address those borders? How do we address those barriers in terms of policy, people movement of products, sharing of knowledge? And I think sharing of knowledge is a really important one to ensure that wherever any individual is, the opportunity for them to maximize their health experience is there.
That makes a lot of sense. I mean, coming back to that story you said about someone asking you for advice and the importance of that equity lens in global health. Do you think that without that lens and broader perspective on global health, that actually you can almost do more damage than good in global health if you have a constricted lens that doesn't that doesn't kind of acknowledge the history and power imbalances in global health?
Absolutely. Not just that, we perpetuate those power imbalances, and it still happens. The typical global health expert, I'm not typical, I'm an anomaly. But even in that sense, the typical global health expert was educated in the global north, mostly North America, Europe, USA and England being the biggest producer of global health experts, and is almost predominantly focused on the selected, subject of interest. They fly in, fix things, fly out. They impose their worldview on the people they're coming to help, while people in those regions where they intervene are not often as equally consulted in defining the problem and the solution thereof. Even let's take health system strengthening, for example. We talk a lot about health system strengthening, and it's a particular passion of mine. But what we do is actually health system, we plug gaps. We don't build the system. We put a temporary bridge so we can cross over and do what we want to do, and then we go away. And the chasm that we needed to cross is still there. The vacuum is still there. That view, conscious or unconscious of, and there was a series, and I can't remember which journal, not a few years ago, that basically said global health is public health, but in somebody else's backyard. And that it was a cynical approach to challenge, to stimulate debate, which it did really excellently. And if I remember the reference, I will share the reference, because I think it's a really good one for people interested in global health. So we still do have a lot of a colonial lens through which we look at global health. It's, people coming to help those people rather than actually, again, looking at equity and trying to understand the broader system and where the global north is actually part of, is complicit, consciously or unconsciously. I still think it is predominantly conscious, in creating those barriers and maintaining those barriers that create the health problems that we propose to want to solve. And so we need to stop seeing global health as an us or them. We need to take that same perspective wherever we are. The fact that there's still, tuberculosis in the pockets of London, one of the wealthiest countries and cities in the world, is a global health issue. The fact that in North America, they have the difference in maternity outcomes for African American women versus white women is massive and not narrowing, in the country that spends the most on health, is a global health issue. So it's not just about, going to Africa or going to India and trying to fix things. It's about looking at the lens of what are these broader policy issues that mean that in certain places, certain populations are not able to optimize their experience of health, and how do we dismantle those systems? And that's why that decolonizing global health agenda is so important, because that colonial lens and mentality is still very much determining what happens. I had an experience in a Facebook group. It's Facebook, WhatsApp, I can't remember. One of those social media groups that I belong to, where somebody, an independent consultant, was looking for partners to support a project she was working on she named certain African countries and said, I just want them for data entry, for data collection. And I challenged and said, why just data collection? Wouldn't they be interested in being part of the full project? And her response, oh, it's my experience that they only want to do data collection. So that's a very large generalization. The country, the 3 countries you mentioned, the collective population there is about, 300 million people. And you're saying that all the people in global health there are only interested in data collection? Or is that the only thing you've ever offered? So that's the question that you see, is how do we actually stop and challenge ourselves to say, what is the lens through which I'm approaching my work? And if you're always looking at it as I'm coming to help you, there's a problem.
I guess coming back to that comment you had about the system as a whole, I think you're a passionate kind of advocate of equity in leadership as well in global health to address these health challenges. Can you speak, I guess, a little bit about what the barrier is in your experience to making global health leadership more equitable, maybe, not only just in terms of, gender, for example, or ethnicity, but what are the kind of barriers in your experience to addressing that imbalance?
Well, the barriers, first and foremost, is that you cannot be what you do not see. So if you never see yourself reflected in the leadership of the big, institutions around the globe, you don't even think that is a possibility. So you don't position yourself to ever be in that leadership position. I mean, it's unconscious policing in effect, that you don't see yourself, you don't recognize that it's something you could be, and therefore you don't even plan towards it. So even if there was opportunity, you never consider that job advert may be one I'm interested in. So that's the first thing. And then there is even though, first of all, more recently, there's been a backlash against the equity journey when we look at gender and ethnicity, even this sort of anti-wokeness movement, which is the most ridiculous thing in the line in recent times. But there has been a pushback against some of the changes that were being made to address both inequity in all its forms, but also the big problem is the institutions. Institutions are like, tankers. You don't turn them around overnight. And unfortunately, what we have is performative and tokenistic statements in response to major global issues. So in the UK, for example, at the beginning of the pandemic with the George Floyd death, there was a whole flurry of organizations making statements and the report around what they decided to call health disparities, talk about hiding things by changing the terminology. But there was a lot of performative statements and commitments to diversity, equity, and inclusion. But what happens now? Go back and look at all those those organizations that made all these statements. Even the ones that have actually evaluated themselves, like the Wellcome Trust, did evaluate what it had done in response to its statement, its strategy that I announced a few years ago around broadening, around addressing diversity, and it said we weren't doing so well. The rest have even just sort of stopped bothering. And I personally experienced, for me, working in Public Health England, as it was at the time, was I actually had a conversation with a comms person. I said, I can speak about communicable disease control, health protection, global health. You don't have to just wheel me out when you need someone to speak about being Black or being a woman. And so those are some of these unwritten barriers. But then aside from that, globally, so stepping back beyond just focusing on the UK, globally, women in science education are still playing catch up. It's improving. It's improving at different paces in different parts of the world. The parts of the world that particularly passionate about in Africa, the rate of improvement is the slowest. But even when women have the education, they've got the qualifications, they are overlooked for promotions. As you know, a woman would wait till she's about 70 to 80% of or more of the requirements of a job before she applies. A man would apply with 40% of those skills. So there's a conditioning of childhood in that also, and this is global, it's not just in Africa, where we condition uh, boys to be risk takers, we condition girls to be more reserved. All those things contribute to women not actually applying for those jobs, even when they're totally qualified. I've done a lot around mentoring, around making sure that women, as I've had the privilege myself of having male allies and sponsors who have, I always talk about is how important it is to have people who will mention your name in the room where it should be heard. That's really important, and it's really relevant. But until we actually change the systems, so that those built-in barriers to women, the fact that if you take parental leave, you will miss out. It is even, there are very few organizations that actually allow a woman to go back to where she would have been on return from parental leave, or who actually support her to be able to do that. So there's of course, the misogyny, the gender-based violence in the racism in workplaces that mean that women are more likely to change jobs after short periods because of those adverse experiences, and therefore climb the career leadership ladder at a slower pace because they're changing jobs. So until we address those institutional barriers, it doesn't matter how well educated, how well mentored women are. And then a critical thing that I think we need to be intentional about, and which is something I'm exploring, say, how do we do that, is creating a pipeline of women leaders for these key strategic positions. What tends to happen is we get a woman leading an organization and the whole world says, oh, well, we've got a woman or we've got a Black person, tick the box. You know, that person's term's done, let's go back to the norm. The woman in leadership is seen as an anomaly, you know, almost, again, comes back to that tokenist. We can tick the box in that we've had a woman. Let's go back to the usual suspect and have a male. Look at WHO Africa region at the moment. We've just had Dr. Shidi Moeti is completing her second term, and all the candidates to replace her are all men. All men. And if we don't do something and are intentional about that, that will become the norm. So we have to create a pipeline. The number of times I have people say to me, but I don't have any women. Africa CDC has now one woman in a senior leadership position. We could do better. We could do better. And that is because, first of all, we need to be intentional about preparing the women. We need to identify those organizations, create a pipeline within those organizations so that people with the potential and interest are supported and seen. Because oftentimes people say, I don't know. And so I actually said to myself, I'm going to set up a directory. Because I know every time I said I can give you 10 names today, you know. So why doesn't everybody know those 10 names? So we need to create those pipelines so that it is easier for those who want to find those women. We need to support those women so that they're ready for leadership when those opportunities happen. That means they also have to have all supported leadership opportunities wherever they are. It's not just about the big jobs. And that takes all of us collectively committing to doing that. And I think it's not about, it will be an advantage to all of us, because I think a system where you have diverse voices contributing to the policies you develop, to the research you do and fund, to how you actually execute your interventions in public health, has got to be better. I mean, it's got to be better. We can't keep going to war with only half of our army. The other half, we've got to put women back. And if you look at it in terms of racial groups, the racial majority are non-white. So why are they not part of the leadership that is defining the world that our children and the next generations after us are going to live in?
I guess moving on a little bit to leadership. So I've been a keen, I guess, follower of your YouTube series. Useful for me, and I know other registrars who watch it, about keeping up with almost this kind of internal conversation as a trainee about how we develop ourselves as professionals, whether that's kind of leadership or how to navigate those kind of career junctions. I guess could you talk a little bit about what prompted you to start the series? You know, perhaps some of the topics you've covered and what you've learned from the experience.
It was one of those. I do a lot of mentorship, but I also am very, when I agree to mentor somebody, it is a two-way thing, and I commit a lot of time to it. So I often don't have the capacity to mentor as many people as would ask me or I would want to. So I thought I should look for a different way to share some of my reflections. And what my mentees will tell you is that it's a 360 conversation that we have. Any of our mentoring sessions, they get a chance, and I encourage them to ask me, is there something you want to talk about? Because I believe, one, that you can always learn. And I have learned so much from the people I've had the honor to mentor over the years. But I also found that with a lot of the mentorship conversations that we have, the things that we talk about are everyday things, which is I haven't solved them. I find that I'm constantly thinking about those things. Sometimes I'm responding in one way and then reflecting, thinking, I could have done things differently. So I thought, well, if these things are relevant for me and they're relevant for the people I'm mentoring, perhaps it wouldn't be a bad idea to share them. And I much as I write when I need to, I prefer to communicate verbally. I think visually and verbally. So I thought, let's do a series of videos. And I've not been as systemic as I want to, but I'm also going to give myself the grace to say, well, not, you best laid plans. You don't always stick to that goal of publishing something every month. But I pick up something sticks, happens and niggles at me, and I'm going to just do it. It's just 3 minutes, 5 minutes tops about that particular topic. I've addressed things like how, procrastination is one thing, and the fact that for me, procrastination usually is an indicator that I shouldn't really be doing that thing, or I don't feel confident in doing that thing. And I have to understand why I'm putting it off and then address it. So that's one example. The other one, I talk about the fact that it should be okay. And it has always, forgive my French, pissed me off when we talk about, especially the UK media specialize in that sort of making a U-turn. Oh God, they U-turned and everything. And I keep saying, Maya Angelou said, when we know better, we do better. So why should we criticize our leaders for learning that, what they initially said may not have been right at all in the past, or it no longer applies and they changed their minds. So I thought it was an important thing to raise with people on their public health journey. Say it is actually perfectly okay. In fact, it is, something to be admired, to be able to learn and change course. If your rigidity is one of the biggest barriers we have, because I said what I said and I'm sticking with it. That's some of the topics. A lot of the topics I've addressed around, particularly my particular interest, women in the space, and the fact that if you're a Black woman in particular, the hierarchy of respect in the system is white male, white woman, Black male, then way down there is white woman. Not even a decade ago in PHE, I walked into a room and was told we're not ready for coffee. Yeah. So when people say, oh, but it is still very relevant and topical today. I had an apology, very profuse apology. The person was not a PHE member of staff, just to be sure. No, but it happened. So we need to, I had my very first leadership training program that and it was an NHS training program that I attended. You do the 360. It was the very first time I had a 360-degree appraisal. I got the classic, you're aggressive, you need to, and the advice from this coach that was part of the program was that I needed to tone myself down. And being my first formal leadership training program, I took that to heart, and I really tried really hard not to tone myself down. And a few weeks into that period, then apparently all the staff in the team had gone to the director to say, we think something's wrong with Ebere because she's... And so in speaking to, it was Ruth Gillespie at the time, who was someone who I admired and worked with a lot. And I explained to her, I said, I was told this in the 360, and she asked for the report, and she said, if I minded, she read it, and she said, ignore that. Look at the bulk of this report does not, and said, and because I couldn't be me, because as you can hear, you can see, I talk with my hands. My passion is what drives me, what I do. And somebody decided to label that as aggressive. If you're a Black woman, you will more likely be called aggressive than assertive. If you're a white man, you'll be assertive. So there's some of these preconceived notions that people use to keep you in place, or the phrase, there's a phrase that really annoys me that people use a lot. I know detention isn't always negative, but when somebody says stay in your lane, I get really annoyed, because they say, this isn't a 100-meter dash. The whole track is my lane. I will be in the lane where you decide I shouldn't be because I ought to be there. So those are the things I talk about, little things, the everyday stuff that I think that even if we don't consciously register it, unconsciously we absorb those things, and it limits our journey. We start to self-police how we do things in the space. So I thought, if you talk about those things, it'll give people a platform to reflect. Because like I keep saying to you, every time that I've made a pivotal career decision is because somebody's asked me the question that has allowed me to pause and reflect. So if I achieve that, I'm very, very happy.
No, I think it's really powerful because you put it out there as a YouTube series to almost get a glimpse into your thinking as a senior public health leader. And as trainees, we don't necessarily get to see that. I mean, which is kind of part of why we're doing, these podcast series, to shine a light on these stories of how do these leadership development and that evolution happen. So I think it's really powerful, and I'll definitely look forward to the next episode.
I will pick
And
up
on the,
again.
but I guess coming back to that, the leadership and how you've kind of evolved as a public health leader, are there any sort of stories or anecdotes that you can point back to that had been kind of pivotal or significant when it came to developing your leadership style? Was it mainly that kind of 360 degree feedback, or were there other moments in your career that were kind of pivotal that had kind of influenced your style?
I think we're all always on a leadership journey, from as soon as we're able to function as part of a society, initially as your family. We get given leadership responsibilities in various contexts, and is defined by the cultural expectations. So for me, I'm Igbo. I'm from the southeast of Nigeria, and in our culture, in Igbo culture, the Ada, the first daughter, has certain leadership responsibilities. So their critical decisions will not be made in the family without consulting the Ada. Responsibility for sort of oversight of your siblings falls with the Ada. So culturally, I think I've always been on a leadership journey, and it's both in case of it's leading from the front as well as leading from behind. Sometimes that leadership is about doing, and to allow others to thrive. Sometimes it's about leading the way. And I would say that for context, I was going to call him baby brother, but he's in his late 40s, so perhaps not. My younger brother, way back when he was my baby brother, used to call me Bossinekers, because I was more directive in my leadership style, I would say, at the time. I also know that as a CCDC, part of the appeal of outbreak controls for me was I liked that sort of command and control that you needed in an emergency response. But over time, I also learned that, and I'm been intentional in broadening my capacity to lead through service, which is hearing what other people's are and giving them a platform to solve it, not fixing it for people. So that's required working on listening skills, being more intentional in hearing the story between what is said, behind what is said, being somebody championing other people. I mentioned already about one of the things I feel that anyone with a privilege to have a platform for leadership should do is to mention the names of others in rooms where they would otherwise not be heard. I have benefited from that, and I continue to benefit from that, and I continue to do that. So I'm constantly using the privilege of my platform to say, so and so could do this. Actually, bring them on, either to work on that with you and then, or you step back and say, so and so should it. I benefited from that. I remember once there was a Chatham House event, a global health event that I went to with Neil Squires, the director of global health in PHE at the time, and there were no women on the panel, and Neil stepped down from the panel and asked me to take his seat. And that is the sort of leadership, is you lead by example as well. So I don't believe in a particular leadership style. I think the key thing about leadership is adaptability, having a pool of skills and resources that you can use when in the right circumstances. But to be able to do that and to be effective, you need to be able to read the room. You need to understand the setting. You need to listen to hear what isn't said. You need to be able to look around. And one thing I always say to everybody is that if you walk into any room, any event that you've been invited to be in, or you, for whatever reason, look around and see who else isn't there. And next time, make sure you bring them with you. So for me, leadership really is about being able to analyze the situation that you're in, understand not just the subject in terms of, public health, the science and the art, but also to understand the culture and those things that people call soft skills, which I think they're not soft, they're harder to acquire actually. Using that, you're listening and being comfortable to make yourself vulnerable, so that you can actually understand what is really needed from you in that space. And then having the skills to then bring what is needed to your leadership at the time.
No, I think that's really, really great, advice, that to have that adaptability leadership style. And I think that'd be really, useful for people training in public health at the moment. So we're coming towards the end of the episode. It's been really fascinating conversation. It's a tradition on the podcast to end with a career tip to those currently training in public health. What is your one career tip to those currently training in public health?
Ooh, that's a tough one. Say yes to the atypical. That will be it.
Yes.
Yes, say yes to the atypical in particular. If somebody offers you or tells you about an opportunity that you would normally, your normal reflex is, that doesn't feel normal, say yes.
Is that really about going outside your comfort zone?
Going outside your comfort zone, experiencing things that are beyond your expectation. I think the UK Public Health Training Program is one of the most valuable training programs you can have the opportunity to privilege to experience. And it provides, especially more so, I think, in the recent decades, there's such a diverse field of training locations and training opportunities that you can have. And so saying yes to that one that just feels, might just be the thing that makes you realize where you need to be. I suppose the converse is also giving yourself the grace to change course. If you're going in a direction and because we all know we need to learn to listen to our guts a little bit better. We've all gotten over logical. And so long as something we rationalize, we say, oh, but it's a good career opportunity. I'll do this, then there, then the map is clear, the road is clear. We ignore the fact that we may not feel quite comfortable about where we're heading. So listen to your gut a little bit more and be willing to do the unexpected if it feels right and it's informed by understanding yourself.
I really like that, and great note to end the episode on. Ebere, thanks so much for coming on the podcast, engaging, and the fascinating conversation. And I hope you've enjoyed the episode.
Yeah, it's been fun. Thanks for having me. I really enjoyed it, and it's good to see you again, Kazim.